Hi, I'm Dr. Sathish Agraharam. I'm basically a retinal surgeon, a retina specialist, and it's been last 20 years that I've been practicing retina. So I am the managing director of Ananda Institute, and which is a tertiary care eye center, which is located at Apsiguda and as well as in Kondapur. Hello everybody, and today I'm going to talk to you about what are all the problems, sight-threatening problems which you are going to face because of diabetes. Diabetes, as you know that India is the diabetic capital of the world, and Hyderabad is considered as the diabetic capital of India. Nearly 16 to 20% of the population of Hyderabad beyond the age of 20 are diabetics. That means if you look around you, every fifth person or sixth person around you is a diabetic patient. Diabetes is of two types. One is called as the type 1 diabetes, where it is an insulin dependent diabetes, and second one is called as a type 2 diabetes, which is a non-insulin dependent diabetes, or where the majority of the times you are treating with medications in these patients. Now diabetes, diabetes, as the duration of the diabetes keeps on increasing, it tends to produce a lot of damage inside the body. So if you want to really understand what diabetes can cause a problem inside the body, diabetes is nothing but a disease of the blood vessels inside the body. So the blood vessels inside the body tend to become very leaky, and they start throwing blood into different organs. Suppose if the bleed occurs inside the brain, then what happens? The patient will develop a paralysis. If the bleed occurs inside the heart, then there is a problem with the patient is going to land up in a heart disease, coronary artery disease, or a heart attack, or whatever in your layman's term it is. The patient usually develops a heart problem. If the same bleeding occurs inside the eye, then the patient starts losing vision, and that we call it as diabetic retinopathy. A similar kind of blood flow abnormalities occur in the kidney, then the patient has to go land up in a diabetic nephropathy, where the patient starts passing more protein in the urine, and the patient ultimately lands up in a dialysis. And if it occurs in your hands and feet, you have seen a lot of diabetic patients where the hands and feet turn very dark, and later they will have a non-healing ulcer, and slowly it will land up into amputation. You have to understand that because of diabetes, all these manifestations occur in different parts of the body. Okay. Now I am going to concentrate on what is going to happen in diabetic retinopathy. So as I have explained to you, in diabetic retinopathy, there is a bleeding which is occurring inside the sensitive part of the eye, which is called as the retina. And so as a result of this bleeding, the patient is going to develop a sight-threatening diabetic retinopathy. Now there are two forms of diabetic retinopathy which the patient usually has. One, when the central portion of the retina which is getting involved, which is called as the diabetic macular edema. And the second one, where the peripheral portion of the retina which is getting involved, where it is called as a proliferative diabetic retinopathy. So imagine yourself when you are seeing certain thing, you want to look very closely into the particular finer details of that particular thing. That particular vision, what is essential for us to read and write and identify people at a distant place, is something called as the central vision. Okay, and whenever you are trying to see one particular object, suppose I am trying to see one particular object, I can see things around me. I can see that there is one computer which is standing next to me, there is a wall onto this side, or there is a switch onto this side. These things are called as peripheral visions. Okay, so diabetic retinopathy can affect both the central vision as well as the peripheral vision. So what happens because of diabetes? If your diabetes is uncontrolled, then it starts bleeding in the central part of the retina, where it produces a condition which is called diabetic macular edema, and hence the patient will not be able to read and write, the patient will not be able to see things clearly now. If the same bleeding occurs in the peripheral part, then the patient will develop something called as a proliferative diabetic retinopathy, where new blood vessels are formed in the retina, and these new blood vessels are going to bleed into the eye, and they produce loss of vision. Okay. So now how do we identify that the patient is going to develop who are all the patients who are going to develop a diabetic retinopathy? If you take type 1 diabetes patients, for the first 5 years, usually they do not develop any form of retinopathy. It doesn't mean that you should not get yourself checked up with an eye specialist, but majority of the type 1 diabetes do not have a disease from the day of diagnosis, at least up to the age of 5 years. After 5 years, there is a very high possibility that these diabetic patients, type 1 diabetic patients, do land up in some form of diabetic retinopathy or not. By the end of 20 years, every patient with type 1 diabetes will have some form of diabetic retinopathy. Whereas in type 2 diabetes is a very difficult diabetes to actually in terms of retinopathy to treat, in the sense these patients can present to you with a sight threatening problem even at the diagnosis. That means in type 2 diabetes, the diagnosis of diabetes itself is very delayed, and as a result of which there are a lot of patients who walk to our clinic where we look into their retinas and say, it looks like you have a diabetes, go back and check, and they go back and check onto their retinas and for their diabetic status, and they find themselves as diabetes. So now what is the best way of identifying the disease inside the eye? So you need to go to your local ophthalmologist and tell them that you are a diabetic patient. Especially I would recommend any diabetic patient who has crossed 3 or 5 years of diabetes to go to the local ophthalmologist. Ask the local ophthalmologist to make sure that you dilate your pupils well and check the retina, both the central part and the peripheral part. That is extremely important. So if you screen your eye once every year till if there is no evidence of any diabetic retinopathy, you need to come back after every year to further screening. If the doctor who is examining you tells you that there is some form of diabetic retinopathy, then you need to keep seeing this doctor once every 6 months. There is not every patient who has diabetic retinopathy needs a treatment. Okay, there are certain conditions where there are certain conditions inside the eye which require treatment. Like for example, if the patient's diabetic macular edema has involved the fovea, or if the patient has got something called clinically significant macular edema. If these two conditions are present, then that warrants that this patient needs a treatment. That is very, very important. So this cannot be identified by the patient. This has to be seen by the treating doctor or the ophthalmologist, or preferably a retinal surgeon who gets into see the retina a little more detail, and they will be able to tell you. The second condition which needs a treatment in a diabetic retinopathy is something called proliferative diabetic retinopathy. So if your ophthalmologist tells you that you have a proliferative diabetic retinopathy, then you need to treat these conditions in an emergency basis. Few symptoms which the patient can look into is, the patient sees multiple black floaters in front of their eye. Some people say that I have seen a lot of mosquitoes in front of my eye. Some people say that I have seen a lot of different kinds of maps in front of me. Each one has their own fertile imagination, and they keep telling you. So if you suddenly see in front of your eyes black floaters and you are a diabetic, well, there is a high possibility that you may have a sight-threatening diabetic retinopathy into your eye. If you are seeing through your eye and you are not able to read and write comfortably, if you are seeing everything is appearing little distorted, when you see a straight line it is appearing a distorted, you have a very high possibility that you are having a sight-threatening diabetic retinopathy. So remember that any patient, a lot of diabetics can have a diabetic retinopathy, but not every diabetic retinopathy requires a treatment. Only sight-threatening diabetic retinopathy, which I told you, which is nothing but a clinically significant macular edema, or a macular edema which is involving the fovea, or if the patient has got a proliferative diabetic retinopathy which requires a treatment. Okay, so what are all the precautions you need to take in order not to develop this kind of a problem? One of the most important thing you need to understand that diabetes is a systemic disease, and if the disease is under very good control, then the possibility of you developing any of the problems which I mentioned before, whether diabetic retinopathy or diabetic neuropathy or diabetic heart disease or diabetic kidney disease, all these incidences are going to be extremely low. So what do you mean by strict control of your diabetes? That is, when your fasting blood sugar is below 100, when your post-lunch blood sugar is below 140, and when your hemoglobin A1C is less than 7, preferably I would say put it less than 6.5. If you can achieve this on a regular basis, a lot of patients, the biggest mistake a lot of patients do is they don't check their sugars regularly. I would strongly recommend at least once in a month you need to check your sugars. And I would recommend every diabetic patient to carry a AccuCheck or a home glucose device monitoring, which you need to check your sugars fasting and post lunch on a regular basis. And once in at least a month, go for a lab value. Go to a standard laboratory, get yourself checked up for your diabetes status, and make sure that your fasting is below 100 and post lunch is below 140. And if your hemoglobin A1C is below, hemoglobin A1C is below 6.5. Ideally, when below 7 is fine. Ideally, 6.5 would be wonderful. It's not enough that majority of the times you see all the diabetic patients are associated with hypertension also, that is blood pressure. So this blood pressure also has to be under control. If blood pressure is shooting to 200 by 100 and your diabetes is uncontrolled, you will still develop a very aggressive form of diabetic retinopathy, because hypertension or blood pressure acts like a fuel to the fire. You already have a disease of diabetes, and over and above that, if your hypertension is also there, then the possibility of you developing these retinopathy is going to be on the higher side. Another very important condition which you need to look into very carefully is, especially more common in females, is anemia. If the patient is diabetic and if the patient is also anemic, then the possibility that this patient is going to land up into diabetic retinopathy is going to be very high. And the last but not one of the very other important common conditions which can aggravate your diabetic retinopathy status is if your cholesterol levels are very high. If your blood cholesterol levels are extremely high, well, there is a very high possibility that this patient can develop very aggressive form of diabetic retinopathy. So make sure that your cholesterol levels are also at a very, very low levels or normal levels. That includes even your other triglycerides and cholesterol, all the different cholesterols which you measure when you do a lipid profile. So in nutshell, keep your diabetes under control, then keep your hypertension under very good control. The blood pressure should be under control. Make sure that you have a good control of your lipid profile, and especially for women, make sure that you do not have anemia, and if you have anemia, get it corrected, otherwise you are going to land up in problems. Whenever you have diabetic retinopathy, remember that there are 3 different forms of treatment. One form of the basic form of a treatment is when the disease in early stage, all the patients undergo a laser treatment. If the disease in the next stage, then we have to inject certain anti-VEGF injections into the eye and then do a laser to these patients. And if a disease is in an advanced stage, and the last stage is the surgery. Remember that as the stages of the disease is increasing, the possibility of you getting back vision is going to be very less. So you have to be very careful. The moment a surgery is indicated in a patient with a diabetic retinopathy, that means that you are in the last stage of your disease, and possibility that you are going to recover back very good vision is going to be on the lesser side. Okay. So one very important point which at the end I would like to tell you viewers is, keep your sugars under control and don't be under the impression that your sugar is under control. Please check it once every month, and all other parameters which I have mentioned, please make sure that they are under control. And I can assure you that if you follow this, more than 95-98% of your chances that you are going to remain healthy. That is very important. It's not that I'm trying to tell you about only eyes, because diabetes can affect all other major organs like the brain, the heart, the kidneys, the eyes, and as well as your nerves. So all the organs are going to get affected, and if you keep your sugars and other parameters under control, the possibility of you landing up any health issues is going to be on the lesser side. Thank you. Hi. I'm going to talk to you about a retinal condition which is called as age-related macular degeneration. Now let's see, every human being ages, right? So what happens when you age? You get gray hair, okay? You also get your knees and joints, or your hip joints, or your spine, everything tends to degenerate, and you're not able to, initially imagine yourself a 30-year-old and you'll be able to run. At the age of 75-80, if you ask you to run, you'll not be able to run. Why? Because your muscles have all become weak. They have undergone something called apoptosis. There is a degeneration which is occurring inside your joints. You're not able to run. Similarly, as you know that the body ages, the eye also ages. And if you see, there is a condition which is called as age-related macular degeneration, where your central portion of your retina, which is supposed to be the active portion of the retina, which is responsible for your reading, writing and identifying people at a distance, that is going to get affected because of aging. Because of aging, what happens is there is a process which is called as apoptosis, where the cells in the retina, behind the retina, that is the retinal pigment epithelium, undergo degeneration, and then the new blood vessels which are there, the blood vessels which are there behind the retina, they try to grow into the central portion of the retina. So what in nutshell they do is they cause a damage to your central vision. Okay, this does not occur in every patient. More than 20-25% of the ages of patients beyond the age of 70 or 75 usually land up in a condition which is called as age-related macular degeneration. This age-related macular degeneration is of two types. One is called as a dry age-related macular degeneration, and the second form is called as a wet age-related macular degeneration. The dry form is the more commoner one, and the wet form is the less commoner one. But wet form is the one which causes more loss of vision. That is, if a patient develops a wet form of age-related macular degeneration, that means this patient is definitely has got a loss of vision. Now, the dry form is where the patients develop multiple white spots inside the retina in the central portion, which is called as the drusen, and these drusen all join together with an overlying area of retinal pigment epithelial atrophy, where they form a patches in the central portion of the retina, which is called as geographic atrophy. So the dry form is all about identifying drusens and identifying dry patches inside the eye, which is called as geographic atrophies in the macula. The wet form is nothing but, in addition to these white spots which are developed inside the eye, the new blood vessels will start forming under the retina in the central portion. Okay, and that central portion in the retina, they start bleeding and they produce blood clot in the central portion of the eye. So now, what does the patient look at? So if you screen a patient beyond 70 years of age, some amount of white spots are seen or some amount of drusens are seen in every majority of these patients. I said 20, 25 or 30% of these patients usually develop this kind of disease. Now, the rest 70% may not have this disease. But so in majority of these cases, in this particular disease, the disease is very difficult to pick up by symptoms of the patient. Okay, so if I see a patient, the patient can still have 100% vision, and still the patient can have a dry form of age-related macular degeneration. Now you can understand, now how do we, some of these dry age-related macular degenerations get converted into wet age-related macular degenerations over a period of time, over a period of next 5 years or 10 years. Now how do we prevent these patients? How do we prevent these patients going into a sight-threatening retinopathy? Like I told you, wet age-related macular degeneration produces sight-threatening retinopathy. Now, one of the very important thing is, one of the biggest risk factors for age-related macular degeneration is smoking. If the patient is smoking and if the patient is diagnosed as a dry age-related macular degeneration, then I think I would recommend the patient to quit smoking, because smoking converts the dry age-related macular degeneration patients into wet age-related macular degeneration, and the patient is going to definitely turn blind. The second important risk factor which has been found out is fluctuating blood pressures. If the blood pressure or associated coronary artery disease, if you don't take care of your blood pressures well, or if you don't take care of your coronary artery disease, the possibility that these patients can develop into wet AMDs are going to be on the higher side. And if the patients do not have a balanced diet, and this is what we recommend: fresh fruits and greens and nuts. They contain basically antioxidants, and so these antioxidants prevent further degeneration inside your retina. One of the warning signal in a patient, a 75-year-old patient suddenly says everything he sees, if he sees a straight pole, if there is a curved, it is appearing as curved. If he sees a straight line, it is appearing as curved. Or when he is reading the paper, he says, I am missing my print. I can read in a line, I can read some print, and on some print I am missing. That means that you need to go back to your retina specialist or your ophthalmologist, ask them to dilate the fundus and check examine the macula with a 78 diopter and do an indirect ophthalmoscopy also in these patients. There is a very high possibility that this patient can develop age-related macular, this patient would have an age-related macular degeneration. Previously, we did not have any form of treatments for wet age-related macular degeneration. We had very few treatments available. But now since the last 10 years we have a treatment which is available, which is called as injecting anti-vascular endothelial growth factors into the eye. The trade names are like Avastin injections or Lucentis injections or Eylea injections. Multiple injections are available, and these injections, the best part about these injections is that out of 10 patients, 7 or 8 patients do definitely show improvement and arresting of this particular disease at a given point of time. So one injection is not sufficient in these patients. You need to take 2, 3. Some of these patients may require 5, 6, 8 or 10. There are patients who have taken even 10, 15 injections also. It depends upon the disease process. It depends on the disease process in the patients. Some of them patients, even after 3 injections or 4 injections, the disease process tends to end, and later the patients may not require a treatment. And even if with this injections also, if this disease is not getting cured, then we have a last option of treatment which is available, which is called as photodynamic therapy, which is another very expensive form of treatment, where we apply laser treatment to special laser to the retina after injecting a dye, a photosensitive dye, and that kills the new blood vessel. But remember that majority of these times, 7 out of 10 patients, we will be able to arrest the disease